Thank you very much. I'll be talking about non-diabetic kidney disease in diabetics. Now this is a physician practicing uroscopy done this is an illustration by Gerald Dow, 1955. So introduced diabetic kidney disease is one of the most significant microvascular complications in diabetes, leading cause of ESRD. However, in diabetic patients, kidney disease other than DKD can develop. Non-diabetic kidney disease can occur either alone or superimposed on DKD. It is important to diagnose non-diabetic kidney disease in diabetes because the management prognosis is different and we have to take a different approach. Now you know that 30 to 40% of the diabetic patients develop kidney disease. DKD is most common, but non-diabetic kidney disease is a substantial minority. 20 to 40% of the patients of DKD biopsied will have a superimposed non-diabetic kidney disease. Regional differences in the etiology are there, and we have more of infection-related glomerulonephritis, focal segmental glomerulonephritis, IgA nephropathy. Now, why non-diabetic kidney disease matters? Because it impacts diagnosis, prognosis. Some forms are reversible or treatable, and you can have a better prognosis. Mislabeling as DKD risks mixed therapy. Now, what is the pathophysiology in diabetic kidney disease? We'll see in detail, but it is hemodynamic stress, RAS activation, and the accumulation of advanced glycosylation and products. Non-diabetic kidney disease may be obstruction structural disease or immune-mediated or infection-related, and they can be overlap between both of these. Mixed lesions are frequent. Distinction requires biopsy, advanced diagnostics. Now you know that in a diabetic kidney disease, initially there are hemodynamic changes at the level of tubules. There is a hyper reabsorption stress, endothelial cells and podocytes. All of this basically either hypertrophy or there is a change in the structure, but there is no damage to the kidneys. However, as the disease progresses, you land up with cellular and tissue remodeling in the form of atrophy of tubules, microvascular rarification, glomerulosclerosis, ultimately leading to inflammation and scarring of kidneys and tubulointestinal fibrosis. So in DKD, basically there is glomerular hyperfiltration at the onset of diabetes, SGLT2 driven deactivation of tubular feedback. There is a persistent hyperfiltration and tubular hyperresorption, leading to nephron hypertrophy and nephromegaly. Cellular stressors, hyperglycemia with oxidative stress, AGs, and epidemic changes causes further damage. There is a damage to podocytes, mesangial cells, tubular endothelial cells, and clinical case is a gradual loss of nephrons. Initial normal GFR, but gradually the GFR goes down, and progressive CKD, eventually decline in kidney size and functions. Aggravating factors are poor glycemic control, obesity, smoking, and hypertension. Now, with non-diabetic kidney disease, what happens is that it may be there before DKD occurs or after DKD occurs. So already non-diabetic kidney disease has a loss of nephrons, which is already there because of non-diabetic kidney disease, and superimposed diabetes basically accelerates its decline, and there is a faster reduction in kidney size compared to pure DKD if not treated. Loss of nephrons is also faster, and there is a inverse relationship. Already we measure the kidney function as single nephron eGFR, and there is already nephrons are decreased. So these initially the single nephron eGFR is increased, and as the damage to these nephrons occurs, you will end up with a end-stage kidney disease. So worsening factors are active disease of the non-diabetic component, which is active, and poor glycemic control, obesity, smoking, hypertension, and rapid progression to CKD and ESRD. So basically, these are the stages: hyperfiltration, silent nephropathy, incipient nephropathy, overt nephropathy, and end-stage disease. Of these, the first three are treatable, that is a stage of hyperfiltration, silent nephropathy, and incipient. These are reversible stages, and once the patient progresses to overt nephropathy, this is not reversible. So if you see the natural progression of DKD, you can see that there is increasing, there is a microalbuminuria, then the albuminuria increases, and then there is loss of EGFR. This is a typical course. Some of them will revert back to normal, lucky ones. In some, there is a rapid decline. Both the proteinuria and EGFR, they shows a rapid decline. And there is this entity which is a non-proteinuric kidney disease, there is only the decline in the EGFR and no increase in the proteinuria. There are four distinct entities. Normally, the decline, you can see that these are slow decliners, the green ones. The blue ones are the ones that is an expected decline, and more than 5 to 6 millimeters of EGFR decline basically is a rapid decline. If you see the normotensive patient, there is a very slow decline in kidney function, but if you add hypertension, diabetes, elevated uncontrolled diabetes, more BMI, CVD, then the decline becomes more accelerated, and the maximum decline is once the patient progresses from microalbuminuria to macroalbuminuria stage. If you have hypertension, the decline is faster. This is the gray bar is the hypertension. So these diseases basically lead to acceleration. So basically, a patient of TKD expected decline or with treatment may not be more than 4 to 5. If the decline is more than 4 to 5 ml per minute per year, then you should think of some other pathology and go for biopsy. Now, what suggests a presence of non-diabetic renal disease in diabetics is active urinary sediments, gross hematuria, sudden rapid deterioration of renal function, sudden appearance of nephrotic proteinuria, impaired renal function with absence, low-grade proteinuria, absence of retinopathy in correct clinical scenario, proteinuria duration diabetes less than 5 years, and signs symptoms of systemic disease. See, in all these, basically, you should go for this. So, microalbuminuria predicts non-diabetic kidney disease. Age, with more age, more chances of non-diabetic kidney disease. Diabetic retinopathy, if it is absent, and still signs of nephropathy, more in favor of non-diabetic kidney disease. Duration of diabetes has no relation with non-diabetic kidney disease. Now, this was a study where diabetic retinopathy was studied, and it was seen that if there is a diabetic retinopathy, especially proliferative diabetic retinopathy, it favors a diabetic kidney disease, but the absence of diabetic retinopathy with nephropathy will favor a non-diabetic kidney disease. So basically what you should do is that if there is a presence of, even in presence of diabetic retinopathy, a presence of nephrotic syndrome, nephritic syndrome, rapidly progressive renal failure, all of this basically will suggest a presence of non-diabetic kidney disease. So there will be glomerular causes and non-glomerular causes of non-diabetic kidney disease, which are listed here basically, and which should be looked for and actively treated. And these are the results of renal biopsy in patients, which you can see there are a host of conditions which are non-diabetic kidney disease which can be treated. Renal survival, DKD survival is poor because of systemic metabolic injury, microvascular disease. But if there is a mixed DKD and non-diabetic kidney disease, the prognosis becomes even poorer. If there is only non-diabetic kidney disease, then the prognosis is better because many of these conditions are treatable. So this is the renal survival. You can see this is pure non-diabetic renal disease where the renal survival is better. This is DKD and a mixed DKD and non-diabetic kidney disease combined. The patient oral survival is better also if there is a pure non-diabetic kidney disease compared to the other two situations. So you should go for clinical history and examination, laboratory workup, imaging, evaluate red flags for non-diabetic kidney disease, kidney biopsy if atypical features are present, tailor therapy based on diagnosis basically. There are biomarkers beyond albuminuria which are being developed. Now coming to the therapeutic principles, cause-specific therapy, fundamental CKD care, glycemic control and AKI prevention. So if there is a glomerulonephritis, immunosuppression, infection, antimicrobials, obstruction, surgical relief, myeloma, chemotherapy, so you should go for cause-specific therapy. Foundational care is good control of blood pressure, RAS inhibitors, finerenone, SGLT2 inhibitors, GLP-1 receptor agonist, statins, antiplatelet agents, lifestyle measures, and metformin also does a wonderful job here. A good glycemic management is required to decrease the progression of DKD. AKI prevention is very, very important because a lot of patients of this CKD may receive NSAIDs, maybe inadvertently given NSAIDs, contrast, Hydration protocol should be there, they should not be dehydrated, and medication should be reconciled, basically looking at the condition. So you should strongly go for AKI prevention, because a single insult to kidney can deteriorate the kidney functions irreversibly. Coming to the newer drugs on the horizon, we have a drug which is dual agonist, that is endothelial type A ETA receptor and angiotensin type 2 type A AT1 receptor agonist, Sparsartan, which is being much talked about, and you will see it introduced very soon. And this is a trial of Sparsartan versus irbesartan in focal segmental glomerulosclerosis, and you can see that there is a greater reduction in urine protein to creatine ratio as compared to irbesartan at 6 weeks, and these benefits are maintained even as at 108 weeks. Also, there is a complete remission was more frequent with Sparsartan than irbesartan in the nephropathy. It occurred earlier, and higher number of patients on Sparsartan maintained remission for a longer period of time without returning to baseline. This is another drug which is zibotentan, which is a selective antagonist for endothelial A receptors, basically, and this was a trial, and they have shown that this drug basically, this is the dapagliflozin. The blue line is the dapagliflozin alone, and this is dapagliflozin with zibotentan in different doses, and you can see there is a much more reduction in the microalbuminuria in this. So a greater benefit in these patients. Also, the BP also is better in patients which are receiving the dual therapy of dapagliflozin and zibotentan, basically, compared to dapagliflozin. So it has better effects on preserving the renal function as well as the blood pressure. So the urine albumin creatinine ratios were decreased to a greater extent in those patients who received a combination of zibotentan and dapagliflozin, and this again is a promising drug on the AVIL. So if you see the combination therapy and pillars of care of DKD and non-diabetic kidney disease, you can see that this drug basically, that is dual ETA-RA agonist, basically are the drugs basically which are much more used in non-diabetic kidney disease, and this is supposed on the lifestyle modifications which we do. So coming to outcome and prognosis, non-diabetic kidney disease offers better outcomes than diabetic kidney disease if it is present alone. Mixed lesions, there is an intermediate prognosis, and CV risk remains high. Future directions are multi-omics, AI in pathology, South Asian registries, and pragmatic trials. Thank you very much.
Thank you, Dr. Akash.